Hello and welcome to RUMC Vital Signs. My name is Alex Lutz. On our show, you'll meet the fantastic people who make Richmond University Medical Center thrive. RUMC is an award-winning, full-service hospital located right here on Staten Island at 355 Bard Avenue. To learn more about the full array of services provided at RUMC, visit our website at www.rumcsi.org. Metabolic or bariatric surgery is the most effective and long-lasting treatment for severe obesity, resulting in significant weight loss and the improvement, prevention, or even resolution of many related diseases, including type 2 diabetes, heart disease, hypertension, sleep apnea, and even certain types of cancers. Many people watch the show My 600-Pound Life or are looking in the mirror wondering whether or not they qualify for bariatric surgery. Today we're going to talk about who does qualify for bariatric surgery, the lead up to weight loss surgery, what procedures are available, and the lifestyle changes that happen post-surgery. With me today is Dr. Alex Barkan, board-certified surgeon, the chief of bariatric surgery at RUMC, and vice chair of the Department of Surgery, and he's the founder of Richmond University Medical Center's Bariatric and Metabolic Institute. Dr. Barkan attended medical school at St. George's University School of Medicine, followed by a residency at Maimonides Medical Center and Hahnemann University Hospital. He then completed a fellowship at the University Medical Center of Princeton, and he's performed thousands of bariatric procedures since entering the field in 2006. Thanks for joining me today, Dr. Barkan.
Thank you, Ms. Lutz.
So let's jump right in. Who qualifies for bariatric surgery?
So the basics have to do with something called the body mass index, and the body mass index ranges from 18 to 25, which is normal range, as we call it. People who qualify for surgery have to have a BMI of over 35 with medical problems, such as sleep apnea, which is snoring at night, or waking up middle of the night, or having pushed by the significant other because they stop breathing if it's excessive, hypercholesterolemia, joint issues, or they have to have a BMI over 40 just by itself qualifies for surgery.
So we're talking about, I believe the term is morbid obesity, is that the term?
So, you know, we've changed the terminology, and we like to specify that these are people that are living with weight, rather than having that designation for patients.
But this isn't someone who could go to the gym and lose a couple of weight. These are people with excessive weight.
Most people who qualify for surgery are about 80 to 100 pounds overweight.
Okay.
So that's the qualifications.
Okay. So once someone says, okay, when they come in, what is the process leading up to the procedure?
Right. So the patient comes in for an office visit. We discuss their medical history and we do a physical exam. We discuss their medications and the things they've done to try to lose weight over the last few years, or how many years it was that they're trying to lose weight, how their success was, and what alternatives they use to try to lose weight. And we determine if they qualify for surgery, and at that point, if they qualify, we go over our program with them.
And what does that program entail?
So the program entails a full medical workup with specialists to make sure that their heart is healthy or healthy enough for surgery, their lungs are healthy enough for surgery. We do also require them to go to a nutritionist to evaluate for nutritional deficiencies or the need for nutritional advice after surgery. We also send them to either a psychologist or a psychiatrist evaluation, which is usually a national standard for all patients who are undergoing weight loss surgery.
And why is that necessary?
To determine the reason for the weight loss, to determine competency, understanding of what the surgery is about, since their anatomy is going to change, lifestyle is going to change, to make sure that they understand fully what they're getting themselves into.
I see. And how long does this whole pre-surgical procedure take, leading up to the actual procedure?
On the average today, it's anywhere from 3 to 6 months, depending on the insurance.
Okay. And what are some of the things that may arise that would disqualify a person from the surgery?
Very few things disqualify a person from surgery unless they have active psychiatric or psychological issues that are not resolved or haven't been treated for a while. They have to be sort of taken care of first. Medically, there is a minimal things that disqualify patients from surgery.
And do you see, is it mostly men or women, a mix of both?
So nationally, it's mostly women, but that trend is changing. There's more men are participating in surgical weight loss as well. But nationally, it's still majority women.
And the Bariatric and Metabolic Institute, which you founded for RUMC, also treats adolescent patients as well, correct?
That's correct. We do treat adolescent patients. We've operated on patients as young as 13 years old, and we also operate on teenagers who need the surgery. It's interesting that teenagers who come to surgery usually have a higher BMI than adults.
Oh, really?
The average BMI for a teenager who comes to surgery is about 50. So teenagers tend to be on the higher end of weight than the adults who come in, if we're talking about relative terms. So there are plenty of adolescents that would benefit from weight loss surgery.
And when it comes to adolescents and even adults, are you seeing that these are people who are coming in because of genetics is causing the weight, or is that what really causes?
There are some genetic components, but usually genetic issues start early in life. They present themselves after birth and persist through childhood. They don't present usually in adulthood or adolescence too. So genetics is a component, but it's not a major component of majority of patients presenting for weight loss surgery.
So is a lot of it, I guess I was going to say lifestyle, but I guess my question is, as a society, are we taking care of ourselves, or are we an overweight society?
Well, obviously we're an overweight society. Statistically, 40% of our population is overweight or obese. Up to 22 million Americans qualify for surgery. So overall, we are a overweight society.
And do you see that in Staten Island as well? Do those statistics hold for Staten Island, or are we slightly above the national average?
Staten Island seems to be a little bit above the national average
really?
Compared to other boroughs and other areas in the country.
And is that sedentary lifestyle?
It's a combination of things, I believe. It's probably lifestyle, probably diet, and overall there's a component of patients with diabetes in Staten Island, maybe disproportionately than compared to other boroughs. That also contributes to obesity. About 50% of diabetics are obese. So all those factors play a role.
Okay. And as people are preparing for surgery, I imagine your staff and maybe some people, former patients of yours, are kind of helping people guide along the way.
Yeah.
Support.
So part of our program is a seminar that people have to watch, a video that we give about a half an hour video describing surgeries. The other component is support groups. We have one support group a month. We have different topics of discussion every month, and the participants are pre-op and post-op. And the good thing about our support groups is the patients are all within our program. So there's no information coming out from the internet or from other sources. So the information comes directly from our program. So whatever issues that patients might have, it's all within our own program. So that's really good for the patients that are coming into the program. So a lot of patients go on the internet, they go to Facebook, they have these support groups, but the people are from anywhere and everywhere, and we don't know exactly where the information is coming from. So it's a good thing that we have the support groups, which gear patients into understanding what they're getting themselves into. They can ask questions that they like of patients who already had surgery with us. And of course, there's also an educational component to the lectures that are given for nutrition and post-op life issues that can come up for bariatric patients.
And the field of bariatrics continues to grow, I imagine. I mean, years ago, you heard about the lap band procedure. That was kind of like the only procedure available, and now there's a number of procedures. And as we're talking, we're going to actually be showing some videos of some of your patients, their before and after photos, and it's really amazing the changes that have come about because of your surgery. But I guess it's a field that continues to expand.
Yeah, it's a growing field. It's an evolving field. Like you said, the lap band was popular many years ago. It slowly fell out of popularity due to issues that we started to see when we've exposed thousands and thousands of people to the lap band. So it's an evolving field. Today, certain surgeries are more popular than they used to be. What happens in the future, we don't exactly know for sure, but we are still evolving and growing. And for now, the techniques seem to be working.
So now someone has gone through, they're ready for surgeries. Walk us a little bit through, what are the procedures that are currently available that are the options that either people can select, or you say this is the option that's best for you?
So most important thing is we don't select the procedure for the patient. We do have a full discussion with them, and it's totally the patient's choice, unless they have other medical issues that preclude them from having one procedure over the next. But overall, it's their choice to decide what surgery they want. The most popular surgery in the United States today is the gastric sleeve, or to describe it in layman's terms, we make the stomach into a letter J, or like a hockey stick, where it's thinner on top, a little wider on the bottom, and that is what the sleeve is. A sleeve is a restrictive procedure, meaning that you just eat much less than you're used to eating. There's no malabsorptive component, meaning that there's no bypass of intestines where food is not being digested. As like the bypass, which is another popular option. Statistically, weight loss is higher with the bypass than with the sleeve overall. The bypass has been around for 70 years and become a very good surgery. It evolved from surgery that was due to ulcer surgery, gastric ulcer surgery, where no medications were available at the time. And so doctors noticed that after they resected part of the stomach in patients, they started to lose weight. And so the bypass sort of evolved from that. And today it consists of two components: a small stomach, size of an egg, and then we bypass a certain portion of bowel. And so to make it easy for people to understand, it's like the letter Y.
Okay.
With part of the Y, one part of the Y connects to the new stomach, the other part of the Y connects to the old stomach, and what the Y meets, the leg of the Y, is where food is not being absorbed again. So that's the gastric bypass in a nutshell. And the newer procedure that's sort of emerging and becoming more popular, but insurance is still an issue in getting it approved, is called the SADI, or the SADI, the single anastomosis duodenal intestinal bypass. So historically, there was a procedure called the duodenal switch. It's a more complicated anatomical procedure to describe than the Roux-en-Y and the bypass, but essentially it bypasses a large portion of bowel where food is not being absorbed, and the stomach is shaped like a sleeve, but a little bigger, and so there's a restrictive and a malabsorptive component, but it's pretty excessive. And because of technically more challenging surgery, it evolved into what it is today. And today it's sort of a sleeve, that letter J, with an omega loop, the Greek omega. We take a certain amount of bowel, we sort of bypass a certain amount of bowel, so you have a sleeve with this sort of bypass. So this is a more emerging procedure, and there's some patients that may qualify for this procedure or feel that they want this procedure. But there's some things like, for example, reflux. If a patient has reflux, this is a contraindicated procedure. So ultimately, all these procedures have positives and negatives. Some patients qualify for some patients qualify for others. But in the end, we try to help the patient make their own decision.
And how long does each procedure take?
So the procedures can take anywhere from 1 to 2 hours for the most part. That's the average amount of time.
That's a lot less than I thought. I thought it would be a little bit longer. And are the procedures, we've had many surgeons on the show, and we've talked extensively about robotic surgery.
Right.
Are the surgeries being performed robotically?
They are.
They are?
They are. Yeah, we do use robotics. We use robotics extensively in the hospital for these procedures. And some patients benefit from the
And that includes the new procedure you just mentioned?
Yes.
Okay.
Yes.
So when you're going in to do surgery, do you have, we ask this of all of our surgeons, do you have a routine? How do you get ready for game day?
Well, my game day is always, I stop, I sort of take a time out, as we do in surgery nowadays. I take a time out, and my biggest concern is making sure patients are safe, that the surgery is not rushed, surgery is done carefully, and I sort of calm myself down before surgery and to prepare myself that way, and always having in mind the patient's safety.
All right. And it sounds like from all of the extensive work that goes into a patient before the actual surgery occurs, you kind of know this person before they're on the table.
Yes, our system is such that we see patients every month before surgery. So we track them to make sure that they're going through their workup process. If they're having issues, we try to help them. So we get to know them over the few months. And also they get a pre-op class before surgery, so to what to expect in the hospital. So there should be no surprises. Everything should be very transparent. There should be no things that they haven't seen or heard before surgery. So that's how we do our program. And then, over the months, since we see them all the time, we do get to know them pretty well, and we get to answer all the questions they have. And so we ask questions up to the last minute, even during the consent process, the day of surgery. So hopefully patients get as informed as well as informed as possible.
And are there concerns with excessive weight and anesthesia?
No, the anesthesiologists are very professional at RUMC. They're very experienced with our patients, and we've had very good success working with them.
So the surgery is over. What is those initial first couple of days like for someone post-surgery?
So after surgery, they recover. In the recovery area, they go to a room in the hospital, and the next day they're started on their stage 1 diet, which is basically clears. We have a nutritionist see them, and they bring a whole tray of products that are geared towards the stage 1 diet, and patients start to drink and start to consume liquid for the most part, and they walk around and they see if they're nauseous, if they have any pain issues, but we encourage movement right away. So there's no catheters, there's no drains in the patient. Patient's up and about the next day after surgery, even after the day of surgery, after they wake up, they go to the bathroom by themselves. So we encourage movement as soon as possible, And their hospital stay is usually 1 to 2 nights. If they feel fine the next morning, they can go home. If they need an extra day, we keep an extra day. And of course, if they need more time, we give them more time. But for the most part, it's 1 to 2 nights.
And how long does the stage 1 diet last?
It lasts 1 week.
Okay.
Then there's 4 total stages of diet. Stage 1 is for a week, and it consists mostly of clear liquids, liquids you can see through, and also protein shakes, which is the most, give you the nutrition. And then there is the stage 2 diet, which is a full liquid diet, liquids you do not see through, also consists mostly of shakes, but there's yogurts, and then there's jellos, and then there's other things. And then it's all listed in an app that we gave patients during their first visit, so they can easily refer to it if they get, they forget what they can do or cannot do. Stage 3 is pureed foods. Stage 4 is regular foods, but regular foods are not heavy meats or dry meats, usually soft fish and vegetables. We tell patients to stay away from hard meats, particularly steak, for 6 months. No alcohol, obviously, for 6 months to a year. No carbonated beverages either, because that fills up the stomach, which is much smaller than it was. So we do have all that listed for them in written form, in app form, and so they should be able to easily remember what they need to do.
And you said stage 1 is about a week?
A week.
And what are how long are the other stages?
1 week each.
Oh, 1 week each.
Yes.
Okay. So by the end of stage 4, they're pretty much back to a diet that's relatively normal?
Well, it's a normal diet, but it has to consist mostly of proteins.
Right.
Their meals are not going to be 3 meals a day. It's going to be 4 to 5 small meals. They need to sort of concentrate on being mindful of what they can and cannot eat, and how they should be eating. So they should be meal prepping. They should be spending time eating. And then they have to also understand that there are some things that they used to like, they might not like now. There's some things that they crave in the past, they might not crave again. But we tend to tell patients that they should eat the things they like, because they don't eat a lot. They should eat the things they like, obviously healthy things.
Right.
So that's how the diet is in a nutshell.
And are there permanent lifestyle changes following surgery?
Well, they're permanent, right? The physical anatomy has changed.
Right.
The psychology hasn't changed. The person's psychology is still the same. So it takes sometimes a learning curve to get to the point to understand how they should be eating and how they should be in general.
Yes.
And some patients get there quicker, some patients take time, but for the most part, eventually they understand, because they are physically limited in how much they can eat.
And you have a support group throughout this post-surgery as well, correct?
Right, so this is where we have the support groups pre and post-op, and we have them every month, and we encourage patients to participate, because statistics have shown that the more patients participate with support groups, the better they do.
I see. And when will a patient start to see the weight loss?
They usually see it pretty early on. It might not be as much as they want it to be initially, but you see it right away within the first visit or second visit. They see it right away. We do encourage them to weigh themselves once a week, but no more than that, because seeing yourself lose weight every day is probably not going to happen. So once a week we encourage them to weigh themselves, and most of all we encourage them to do their diet correctly. That's the most important thing, and of course exercise. So we do add that component as well. But weight loss starts almost immediately.
And is there a point where a patient may plateau or stop losing weight and become discouraged? How do you handle it?
So 100% of people lose weight.
Okay.
100%.
Okay. Good to hear.
Yes. To what extent they lose weight depends on them. It depends on the surgery and depends on them. The average weight loss for a sleeve can be 60 to 80 pounds, but it could be 150 and 200 pounds depending on the patient's participation with diet and exercise. So that's still very important. Bypass, overall, statistically, weight loss is more, just the surgery itself. But if you want to maintain or lose a significant amount, then it does require you to diet and exercise participation.
And so you can plateau and then lose weight again?
Yes, yes. That's why we ask them to weigh themselves once a week, because they don't want to get discouraged. But it's true. You can plateau and then you start to drop again, or you can, and then, so there is that. So there is no real timeline. And the average, we talk about a half a pound to a pound a week. That's good weight loss.
And so it also sounds like it's managing a patient's expectations. Someone may go into thinking they're going to lose this amount of weight, and it may happen over time, but maybe everyone's, I want to lose it now, and it might take longer than
yes, I mean, it depends on the age, depends on the sex. So an older individual might take longer to lose weight. A younger individual might take less time to lose weight.
And is, I forgot what I was going to say, So sometimes when someone has the weight loss surgery, there's excess of skin. Do you also do skin removal?
Well, I don't personally do it. We do send it to specialists like plastic surgeons who do specialize in body contouring, and so they may require body contouring surgery afterwards.
Does that frequently happen, or?
It does. It does. I mean, patients will have loose skin. I mean, that's just the nature of the surgery. Not everybody will have loose skin, depending on the body habitus. So men, for example, most of their obesity is in their abdomens or android obesity. And once the abdomen comes down, they might have some loose skin, but it might be as troublesome. Women have gynoid obesity, where their obesity is more in their buttocks and in their arms, less in their abdomen. So that might have more loose skin, and the women might feel more self-conscious about that, and they can seek help to have that skin removed.
And if a woman has the weight loss surgery and then is considering a family, are there restrictions on that?
So we talk about 2 years of not being pregnant after surgery. So not because the child or infant is affected, it's because you disrupt the weight loss process, and so you sort of want to be able to lose your max amount of weight, which takes about 6 to 8 months, up to a year, sometimes up to 2 years. So we don't want that disrupted. So ideally, 1 to 2 years, preferably 2 years to wait before getting pregnant.
And this whole process, is there any different for adolescents who are going through the surgery as opposed to adults?
The workup is pretty similar. The only thing about adolescents, we look at their fusion of bones and their growth plates. If their growth plates are fused, we probably will be able to operate. If the growth plates haven't fused, there are some controversies about operating on these adolescents or not. We've had both situations. We haven't seen clinically a big difference, but that's the only criteria that changes between adolescents and adults.
Yeah. And I guess with adolescents, you're also at the mercy of parents keeping on top of their child with the post-surgery diet and all that.
Yeah, adolescents, that's very important. Have a multidisciplinary approach, having the family on board. Your family have to have family support and understanding is very important for adolescents to be successful.
And what drew you to weight loss surgery as a profession?
Well, when I was a resident, laparoscopy was evolving and growing into a major field, and bariatrics became very popular because of laparoscopy, and so that the anatomy was interesting, and the surgeries were interesting, techniques were interesting, and it was nice to see patients be happy after losing weight. Their lives completely changed. They do things that they weren't able to do before. They're able to, they forget the car keys at home. They don't even think about being short of breath, running to the house and picking them up, or walking their grandchildren around the block. So those things are very nice to see patients happy afterwards and being able to change lives.
It must be amazing for you to see someone at the first start of this process and then walk in and look like a different person.
Oh yeah, sometimes you don't recognize these people and say, no, I got it. But a lot of times you're very happy to see them change their lives and being healthy.
And how many of these surgeries would you say you've done in your career?
Well, it's been about 15 years or so, maybe even more, since 2006, so about 16, 17 years now. I would say probably a few thousand, in the thousands range.
Wow.
Yeah. Yeah.
So if someone is watching this episode and considering weight loss surgery, what would you say to them?
I would say that they should definitely come in for a consultation and discussion. Surgery is elective. Nobody will force them to have surgery. Nobody will push them to have surgery. But if they qualify for surgery and they've tried different techniques of losing weight and they were successful but then regained weight, this is a very effective and solid option to have a persistent weight loss for many years.
Great. And for our viewers, we're going to have the number to the Bariatric and Metabolic Institute coming up on your screen if you'd like to call Dr. Barkan and get a consultation for weight loss surgery. I want to thank Dr. Barkan for joining me today on our episode today of RUMC Vital Signs and for keeping our community safe and healthy.
Thank you.
The contact information, as I said, will be coming up on your screen in just a few minutes. So if you're considering bariatric surgery, give Dr. Barkan and his team a call today. Richmond University Medical Center has cared for Staten Island and the New York City metropolitan area for nearly 120 years. You can help ensure that care continues for decades to come by making a financial contribution to the hospital. Donations can be made in your name, the name of a loved one, or to honor a special nurse or doctor at Richmond University Medical Center. To donate, visit our website at rumcsi.org and click on the donate button located at the top of the homepage, or you can call 718-818-2106. In the meantime, that just about does it for this episode of RUMC Vital Signs. Thanks for joining us. I'm Alex Lutz.